So, Gareth, it's been a long while since we've chatted, and it's a great pleasure to have you join me on this podcast. I haven't met you for years, but
No,
I
it's been
wanted to
fun.
catch up with you because here's the thing, Gareth. There's been a lot of interest in the English method of foam sclerotherapy recently.
Yeah,
And you were one of the founding members on the board of the BAS
yeah,
more than 20 years ago
yeah. You
when,
make me feel old.
well, hey, experienced is a word I
Yeah,
prefer rather than old. We're very experienced, you and I.
okay.
And I sense that there probably isn't anybody now more experienced in foam sclerotherapy than you. You're certainly one of the original promoters of foam sclerotherapy in the United Kingdom at a time, I have to tell you, when we were still doing surgical high ties and stripping.
Yeah. Some
And
people still
you,
are, Haroun.
well, I find that amazing to hear. I mean, do you know that as a fact?
Oh, yeah. There are colleagues in my own organisation, NHS organisation, who are still doing surgery for varicose veins.
And just to be clear, because some people, their jaws will be dropping listening to that,
Mm.
do you really mean that they make a cut in the groin,
Yeah,
tie off the tributaries and put a
yeah,
stripper down the vein?
yeah,
In 2025?
yeah,
Amazing.
yeah,
Well, you and your colleagues, you're going to tell us a little bit about the history of foam sclerotherapy in the United Kingdom. You and your colleagues promoted foam sclerotherapy at a time when even endothermal ablation was not really very much on the scene.
yeah,
And I'm hugely amazed to hear that despite all the promoting you've done and all the research and publications and refinements in the way that foam sclerotherapy is done in the United Kingdom, that stripping is still done in 2025 in the United Kingdom. So tell me, how much foam sclerotherapy do you think now is being done in the United Kingdom?
I think that's a very difficult question to answer. I work in the public and private sectors. Certainly in our national health practice, it's a very small fraction now of what we used to do. I know provision of varicose vein services is very variable, depending on where you live in the country. In Birmingham, up until COVID, we were allowed to essentially treat any patient who presented us with symptomatic varicose veins, C2 and above. We weren't allowed to do telangiectasia and what have you. But then COVID came along and everything ground to a halt, and the CCGs, as were the ICBs now, came up with a set of criteria along, in consultation with the trust. And basically now we're only allowed to treat patients who have highly symptomatic varicose veins, so C4B or bleeding or active or healed leg ulcers. That's all we're allowed to do. So back in probably the mid 2000s, I was probably doing 600 or 700 a year. Now, personally, 50 maybe on the NHS. But of course, what that means is that the private practice has boomed. The private practice is very busy. Foam sclerotherapy is an extremely affordable treatment. So, a lot of patients will spend more on a holiday than they will on having their legs treated for varicose veins in our practice. I know the prices are variable as well. um, so how much is being done in the country now? I don't know. I think there was a survey done by the Vascular Society of Great Britain and Ireland many years ago now that asked about treatment for varicose veins, and something like 80% of the respondents, probably more than that, I can't remember the exact figure because it was a long time ago, said that they were doing foam sclerotherapy. But I think that a lot of people have very different ideas about what foam sclerotherapy actually is. And I think that's one of its weaknesses. Superficially, it appears to be a very simple and straightforward thing to do. But I think in order to get good results, it's far from that. I think it's probably the most complex way to treat varicose veins. It requires a great deal of attention to detail, a bit of imagination. It's not like RFA, for example, where you bang the catheter up the vein, press the button, withdraw the catheter, that's it. There is no standard operating procedure for foam sclerotherapy. And so I think a lot of people are doing it, but perhaps not in a way that I would recognize or understand.
I think you're right. Well, at this juncture, Gareth, I'm going to pause. We're going to watch your presentation. You very kindly put together a presentation about the English method and the history of foam sclerotherapy in the United Kingdom, principally in England where it started. We'll watch that and then we'll come back and I'll have a chat with you about it afterwards.
Yeah, great.
All right then. Okay.
Thanks ever so much for asking me to participate in next year's British Association of Sclerotherapy Conference. I haven't been for a while, so it'll be nice to catch up with folk. You've also asked me to put together this presentation to introduce myself a little bit and explain how I came to be interested in varicose veins, and latterly just to explain about our modern, if you like, technique for treating varicose veins with foam sclerotherapy. My interest in vascular surgery developed in the early 1990s whilst I was working in the operating theatres. In 1995, I was asked by one of the consultants to take up a role as CNS in vascular surgery. About the same time, one of our consultant interventional radiologists, a chap called John Henderson, suggested that I learn to ultrasound, and for the next couple of years, I spent one session a week with John in the X-ray department, scanning anything that moved. Veins, arteries, aortas, carotids, kidneys, I did the lot. This also coincided with the introduction of portable and affordable, or relatively affordable, ultrasound machines. This was the first machine that I had. This was Sonosite 180 Plus, and it basically transformed our assessment of patients with venous disease. Every patient who came to clinic got a scan, and we weren't left relying on educational guesswork and a handheld Doppler when looking at potential treatment for superficial venous incompetence. Everything really changed for me and took off when this chap, Andrew Bradbury, was appointed to the chair of surgery at the University of Birmingham. Andrew had previously been a consultant in Edinburgh, and he'd been awarded a large NIHR grant to investigate treatment of what was then called critical limb ischemia. He took up his post in early 2000, and he was looking for somebody to help him with this research. I applied, and I was fortunate enough to get the job. Now, the academic department of vascular surgery in Birmingham was brand new at this time. We had no money. So later in 2000, when we were approached by a company called Provensis to participate in a clinical trial for which we would be paid, we jumped at the chance. Provensis were trying to develop a commercial microfoam product for treating varicose veins, and were conducting a randomized controlled trial comparing their product, which was called Varisolve, with standard surgery. We randomized around 30 patients into that trial, half of whom received foam, half received surgery. Now, back in those days, we were taught that sclerotherapy for proper varicose veins really didn't work, and we had no expectation that the foam would be any different. So we were amazed when we saw the results. Indeed, we were so impressed that we decided to continue using homemade foam after the trial had ended. Provensis continued to develop their Varisolve product. It took them many, many years and hundreds of millions of dollars, and is now known as Varithena. As far as I'm aware, the only country in the world where this is licensed is the United States, but I may be wrong on that. At this time, Philip Coleridge-Smith was also using foam to treat varicose veins, and I visited Philip in his clinic very early on, and we learned an awful lot from him and his team. Indeed, we've worked closely with him ever since, running many training workshops over the years. We were an academic department, so we tried to introduce foam in a scientific manner. Of course, we had to go through the hospital's Novel Therapeutics Committee, and I kept comprehensive records of all of our treatments for many years. We also supported several venous research fellows, including Katie Darville and Hugh Davis. I personally followed all of our patients up with face-to-face appointments and duplex scans at 1, 6, and 12 months post-treatment and annually thereafter for several years, keeping accurate records. And this wealth of data facilitated the publication of many papers. By the middle of the noughties, foam sclerotherapy had become our method of choice for the treatment of superficial venous incompetence. When endothermal techniques were introduced, again around about the middle of the noughties for us, we quickly realized that these treatment modalities were very complementary. Another interest of mine is improving the lot of patients with leg ulcers. The ESCAR trial had told us that correcting superficial venous incompetence was beneficial in terms of reducing ulcer recurrence, but many of us who treated large numbers of leg ulcers also believed that it improved ulcer healing. And we published a couple of papers, admittedly only case series, which supported that view. So when Alan Davis and co published the EVRA trial results in 2018, we were delighted to see that borne out, and we were very happy to be participants in the EVRA trial. Anyway, that's enough about me and the dim and distant past. Let's move on to the technique that we use for ultrasound-guided foam sclerotherapy today. When we did the Varisolve study, we were taught to use a single cannula at around about the level of the knee, inject the foam, quite large volumes of foam in those days, and milk the foam around up and down the trunk and into all of the various tributaries. We've come to understand these days that this is not very efficient, and we need to get fresh foam into all segments of the veins being treated. Nowadays, we aim to place a cannula every 20 centimetres or so. If we're treating the entire length of the great saphenous vein, for example, we'll often put 2 cannulae in the thigh and 2 in the calf, plus cannulate every significant superficial tributary, as we know that these are often the site of recanalization when veins recur. Cannulae are all placed under ultrasound guidance with local anaesthetic, and the patient is appropriately positioned on a couch. We do not use butterflies, as we find that these can cut out very easily, and we do not cannulate veins with the patient standing upright. Not all cannulae are equal. We don't like the safety cannulae. In our experience, the best cannulae to use are Optiva 2 from Smith's Medical. These are very sharp and low profile. They go into veins with thickened walls very easily. We use a combination of 18, 20 and 22 gauge cannulae depending on the depth of the veins being targeted. The longer cannulae go into the trunks, whereas the shorter 22 gauge cannulae are used for superficial tributaries. This is also a useful aid memoir as we use lower concentrations of STS foam in the superficial tributaries. When all of the cannulae are in position, we lie the patient supine and elevate the leg to reduce the pressure in the veins, thus minimizing the dead space. We start injecting proximately and work our way distally. We do not attempt to compress the sphenofemoral junction or sphenopopliteal junction for 3 reasons. Firstly, it is very difficult to compress the superficial vein without compressing the deep veins, thus trapping foam in the deep veins. Secondly, even if we do manage not to compress the deep veins, when you release the pressure, you're likely to get a bolus of foam from the superficial veins spilling into the deep veins, which is obviously not desirable. And thirdly, even if you can compress the superficial vein whilst leaving the deep vein open, you simply don't stop foam spilling into the deep veins. You can always see bubbles in the deep veins, but this just gets protein bound and washed away. We inject small 2 ml aliquots of foam slowly, and we use the minimum required concentration and volume of STS, 3% for the trunks, 1.5% in the superficial tribs. We believe this minimizes the chance of respiratory or visual side effects. We ask the patient to perform active ankle movements between injections to flush the deep veins, And when the veins are full, we stop injecting. Once the veins have been adequately treated with foam, we compress the leg using wool, pair haft, and a compression class 2 stocking. This achieves a nice balance of high ambulatory compression and lower but still adequate resting compression. We ask our patients to go for a 15-minute walk as soon as the stocking is in place before they go home. Thereafter, we ask that they walk for a minimum of 5 minutes each and every hour that they're awake for the first week after the treatment to reduce the risk of venous thromboembolism. We ask them to wear the bandage and the stocking untouched for 3 days, after which time they remove the bandaging and continue to wear the stocking day and night for 1 week and then day only for a further 2 weeks. All patients are provided with written post-foam sclerotherapy instructions, which includes our contact details. We stress the fact that tenderness, lumpiness, and discoloration over the treated veins is not uncommon and is nothing to worry about. Patients are asked to contact us if they have any concerns. Thrombophlebitis is not uncommon and is often easily resolved by aspirating the sclerothrombus under local anaesthetic and ultrasound guidance. This usually produces immediate symptomatic relief. In our experience, this is best done between 2 and 4 weeks post-foam sclerotherapy when the sclerothrombus becomes gelatinous. We advise all patients that it can take 6 to 12 months to see the final cosmetic review after endovenous treatment. So that's a brief summary of the modern technique that we use to treat our varicose veins with ultrasound-guided foam sclerotherapy. We seem to have very good results. I've had the good fortune to travel quite widely teaching this technique, and I see a lot of people struggling with it. It is quite nuanced. It's a very subtle technique. I think it is more of an art than a science. One of the problems with foam is that there is no standard operating procedure, if you like, as there is with the endothermal techniques. And many people have many different techniques for doing foam, but this works for us. Our patients seem to be very happy with it. We've published patient satisfaction results, and at the moment we've got no reason to change what we do. So I hope that's been helpful for you, Haroun, and I look forward to discussing this with you further at the British Association of Sclerotherapists Conference next year. Thank you. Cheers.
So, Gareth, having watched that video, it's clear to me that this is the nearest that we have for a standard operating procedure for foam sclerotherapy. It's taken some of the variability out of what's called foam sclerotherapy out of the equation and standardized it to a greater or lesser extent. If you had to explain to a complete novice in just a couple of sentences, what are the principal features of the English method that makes it different from other ways that are done perhaps in the United States or perhaps in Europe? What's different about the English method?
It's a method that has been adapted over the course of 25 years, really. Well, probably 20 years. I don't think our technique has changed greatly in the last 5 years or so. I think we quickly came to realise that that you needed to get fresh foam into every sort of 20 centimetres, 8 inches or so of vein in order for it to be effective. So when we first started, we were doing a single cannulation in the thigh because that's what the trial told us to do, and trying to melt the foam around. And although the short-term results were good, there were significant numbers of recurrences fairly early on. So we quickly, and as we became more adept at cannulation, that's the other thing. I mean, you know, it's I often say to people who come to watch us and to learn, You can't be a good bricklayer unless you lay bricks every day. Well, the same thing is true of phlebology as far as I'm concerned. You need to just do thousands and thousands and thousands of cannulations. So once you get good at cannulating, you can cannulate any vein sort of down to about 1 millimeter in diameter, providing there's a little bit of straight stuff. And so I think the use of multiple cannulae and altering or varying the concentration of the foam that you use depending on the size of the vein are probably the most important changes that we've made to the technique since we first started. Does that answer your question?
Yeah, it does. I mean, a lot of people still ask me how to go about treating the trunk, or should we be treating the trunk first, then the tributaries? And should we start at the top and should we work our way down? And I've always said, and correct me if you think this is wrong, I've always said, place all your cannulae in the trunk, then in the tributaries. And when you are administering the foam, start at the top of the trunk, so whether it be the GSV or the small saphenous, and work distally. Is that what you do, Gareth?
We tend to start proximally.
Yes.
We would always cannulate the trunk first, but we kind of do the big tributaries as well on our way down the leg.
Yes.
So if we were treating a full length GSV, we'd probably put 2 cannulae in the trunk, in the thigh, 2 cannulae below the knee into the trunk, but also cannulate every major tributary that we can see. The most cannulae I've ever put into one leg, I think, is 12 or 13. But it gets a bit silly after that because there's a limit to the amount of foam that we can use. Although I know a lot of people use more foam than the license volume. But we tend to stick with reasonably low volumes of foam. I think I've probably put 20 mils of foam in a single, or probably used 20 mils of foam in a single treatment session, probably about half a dozen times ever. And unless the patient has got ridiculously extensive varicose veins, I think you can do everything pretty much in one sitting without that, without using massive volumes of foam and going to silly numbers of cannulae. But yeah, so that's what we do. And then when we inject, we start injecting proximately and work our way down. And then I usually, just through habit, do a double shot at the top, like you do with RFA.
So you would go back. You'd go back to the top and put a bit more in at the top.
Normally do another dribble at the top, yeah, just to make sure it's kicked into touch. Good and proper.
That's it. How close would you get to the junction at the top with your cannula?
I'd probably be a bit reluctant to go within about, I don't know, 10 or 15 centimeters. You just kind of get a feel for it.
Yes.
Clearly, you're not going to be wanting to pump lots of foam into a cannula that's placed bang on the junction.
No.
I don't know. Yeah, 10, 15 centimeters maybe. There's no set rule.
Okay.
And with sorry, Haroun, I was just going to say, with small saphenous veins, our practice, if we can do it, is to place a cannula retrograde as proximally as possible into the small saphenous vein. So we're injecting downhill away from the junction. And then we'll put another cannula distally to inject antegrade.
Yeah, that's great.
But you can't. Well, I suppose you could do that to the great saphenous vein, but you'd be coming down a long way below the junction, I think, to get access.
Yeah, I have to say that in the early days when I started doing foam sclerotherapy, I was always very frightened when I saw bubbles in the deep veins.
Sure.
When you teach, and I know you've done a lot of teaching, you've demonstrated this technique and widely and internationally. You've been abroad and you've
I have. I've been very fortunate. I've been some interesting places and seen some interesting techniques. Let me tell you, and not only internationally but in this country as well.
Yeah. Well, yeah. Hey, if we want to go and see stripping, we know where to go. Then I'll have to speak to you afterwards, and you can tell me. Memory lane. Tell me What do you say to people who say, "Oh my goodness, there's bubbles in the deep veins. I'm going to cause a deep vein thrombosis." What's your reassuring advice on that one?
So there are a number of things that I say. First of all, I say to them, draw up a 5 ml syringe of saline for injection and watch what happens when you inject that into an intravenous cannula. So liquid saline, inject it normally. There are bubbles all over the place when you inject it through a cannula. So number one, whenever we do an IV injection, we're injecting bubbles. Number two, we know that this sodium tetradecol is deactivated when it mixes with blood. It becomes protein bound. We inject very small volumes, very small aliquots of foam, 2 ml at a time, and we inject it quite slowly. And when the bubbles hit the deep vein, they just get flushed away, and they don't cause any bother. We know from when we were doing the work for Provensis in the very early days, and we did a study called, I think it was called Vanish 1 from memory, and they did CT scans of the patients' brains, and we know that there were bubbles seen all the time in the middle cerebral artery and what have you, but it didn't cause any harm at all. So I'm not particularly concerned about it.
Okay.
What else do I tell them? There's various things, but yeah, we get them to, we get patients quite often to actively move their ankle in between each injection as well, just to increase the flow in the deep veins and flush the bubbles away. So, but it's not a problem, and you can't stop it happening. You know, it always
Okay.
happens, regardless of
So
where you inject.
yeah, and what maneuvers you use, like
Yeah.
pressing on the junction, or
We do not do that. We stopped that a long time ago, because so we do our try. I said I showed this in the presentation, I think, but we have our patients supine during treatment with the leg elevated. That way, you know, if you inject bubbles into a liquid, bubbles rise, so the bubbles mostly going up towards the foot rather than the head. But also, when you've got a patient in that position, it requires not very much pressure at all to occlude the femoral vein. So you're potentially trapping foam in the femoral vein, which would not be a good idea. Secondly, when you release that pressure, you potentially get a bolus of foam flying off into the femoral vein, which is probably not a good idea either. So, and even if you do manage to compress the saphenofemoral junction without compressing the femoral vein, you still get bubbles in the deep veins anyway, because they find their way around. So we abandoned that donkeys years ago as not only an ineffective thing to do, but potentially a harmful thing to do.
How persuaded are you that elevation of the leg is an essential part of the technique?
Well, I know a lot of people don't, but it's just what we do. It's what we've always done. It seems sensible. Um, there's no downside to it, as far as I can see.
Well, I have to tell you that some of the board members, I won't name them, some of our current board members have abandoned leg elevation, because the reason being, not because they are not persuaded, but because they work in clinics where the treatment room might be quite small, the couch may not be, it may not be amenable to having a drip stand moved around to be able to get the leg elevated, so they've abandoned that. And they find that it's quicker, and they haven't noticed any difference. But I take your point. You've got a routine; it works. Why change it?
Yeah.
Have you been persuaded about the possibility of using long catheters and tumescence around the vein? What's your
No.
what's your take on?
I know the gentleman who started doing that reasonably well. I like it very much. But it's people have a tendency to want to overcomplicate things. I don't know whether it's part of human nature or part of medical nature. I don't know. But a lot of people, when I've travelled around the place, seem to just want to make it more complicated than it needs to be. So, as I said before, if you're good at cannulation, if cannulation isn't a problem, why not just do it? It's cheap, it's easy. You get fresh foam all the way. You haven't the tumescence thing. Absolutely, it's horrible. It's a horrible experience for the patients. So no, Not
No.
convinced at all.
All right.
My
Now,
personal opinion.
no, that's all right. I mean, the thing
Yeah,
is, a lot of phlebology is personal opinion.
yeah, yeah.
The science
There's
behind
no,
any of these things is actually quite poor for
yeah, yeah, and the
a lot of
evidence
these
behind
things.
it is non-existent.
The
So
evidence for a lot of things that we do is
yeah,
non-existent,
yeah, yeah,
and it's all based on anecdote. But
yeah,
what I would say is that the method that you have outlined in your presentation that we've watched has a lot of publications behind it that
yeah,
support it
yeah.
and provide evidence that we get closure rates and quality of life improvement, perhaps, which is just as important, if not more, which is equivalent to endothermal ablation. I
Well, I
want
think,
to ask,
sorry, can I, sorry to interrupt. Just on that point, I think it's quite important from the patient's point of view. When the patient comes to see you, they want essentially two things. They want their legs to look better and they want their legs to feel better. And they don't really care whether the great saphenous vein is occluded or partially recanalized. And providing their leg feels better and looks better, they're happy. So I think the use of occlusion rates in venous studies as a primary endpoint is wrong, because that's not what we should be looking at. We should be looking at patient satisfaction. And that is one of the things we've done. And also one of the things that Lars Rasmussen did. Um, the very famous study that he did, and the patient satisfaction rates were the same regardless of what you did for the patient.
yeah, exactly. No, I'm with you on that one. I totally agree.
Mm.
I think phlebologists do two things, and I think you've mentioned them. They tend to overcomplicate, and they also tend to have this obsession with recurrence rates as judged by duplex
Yeah,
and recanalization. And you're
yeah,
quite right. If you look at patient-reported outcomes, there's no difference.
yeah,
Patients are equally happy.
yeah.
Now, here's the thing I wanted to ask you, because you've had experience of the private sector, the NHS, you've had experience of foam sclerotherapy, you've had experience of endothermal, you've worked with people treating the less severe end and right up to ulcers. How are we going to address the leg ulcer crisis in the United Kingdom? We've got more leg ulcers appearing than we can treat. We've got more people waiting with active leg ulcers than there are cannulae available, endothermal ablation kits. We've got a declining number of treatments. Is foam sclerotherapy the only answer?
Um, no, obviously it isn't, because many people we see with leg ulcers don't have superficial venous incompetence. I mean, I know you can still put foam. You can put foam into any vein, and you can put foam into the veins under the ulcer. That's fine. It's not something that we do. I do a lot of my NHS work is leg ulcers, and I think that the treatment of, I can only speak for my own location, but I think that the treatment of leg ulcers is just shockingly bad. It's awful. We have patients who come for months, they've had them for months and months and even years, have never been in compression, and they're sitting at home, and this wound is becoming more and more chronic, and it's festering, it stinks, they won't go out. It's just shockingly bad. We've known how to treat leg ulcers for millennia. There are pictures on the walls of the pyramids in Egypt of patients having their legs bound up. And we still can't get it right in what is supposed to be a first world country. And I think it's absolutely appalling. And to my mind, they're one of our, people with holes in their legs and painful holes in their legs. They should be our priority. We're doing all sorts of nonsense in vascular surgery at the moment. Not nonsense, maybe that's too strong a word, but we've lost track of what really matters. And it goes back to what I was saying before about the occlusion rates being the primary endpoint in many venous trials. We should be concentrating on what the patient wants, and PROMs should be the most important thing. To have an elderly and often infirm patient with a hole in their leg who's not getting appropriate treatment for months and months and months on end is just appalling.
I don't expect you to solve the leg ulcer. By
I
a
do.
leg ulcer crisis, I mean venous leg ulcers.
I've been
What?
trying for well, I've been working in the field of vascular surgery for 35 years, and the whole of that time I've been trying to improve the lot. I've been speaking to people in primary care, nurses and doctors, and what have you, and I've had absolutely no success. And one of the things that's happened recently in my own location, and I do my leg ulcer clinics at Solihull Hospital, is that the primary care in Solihull, they're organised into two big primary care groups, all of the GPs, and they've recently stopped their practice nurses seeing patients with leg ulcers because they're not getting remunerated for it.
There's a funding problem.
Yeah.
So, I mean, I'm out of it for a little while, so I don't really understand it. So, are you saying to me that if I had a leg ulcer in your area, my GP would just say we can't see you?
Your practice nurse would. I mean, the GPs don't see patients with leg ulcers.
So the practice nurse doesn't see them, the GP doesn't see them. Who sees them?
The practice nurses, I think they've been told that they can see a patient for about 6 weeks, and if it's not healed, they've got to shunt them on to the district nurses. The district nurses are completely overwhelmed, and obviously our population is getting increasingly elderly, increasingly obese. And all of these things are contributing to the increasing numbers of ulcers that we're seeing. But they're not even getting the basic first aid, which is washing the leg. You know, nobody gets their legs washed in primary care unless they take their own bandages off. And they're not getting compression.
So those are the two real things that could make a difference.
Yeah. It's not
Is there
rocket science.
is there any point? Is there any point in people high up in the Venous Forum or the Vascular Society banging on about this at their meetings every year?
I think we've got to keep going on about it, and we've got to keep trying. And
But we're banging on to each other, aren't we? I mean, what's the point?
We are.
What's the point of you attending a meeting to be told there's a leg ulcer crisis?
Well,
can we?
I think one of the things you've got to remember is that the people who attend the meetings are the enthusiasts. But 99% of the people who are actually dealing with the problem at the coalface, so to speak, are not coming to the meetings.
But it seems to me, from what you say, Gareth, that there is no coalface. The GPs won't see them, the practice nurses don't have time, and the community nurses are under-resourced. Nobody's at the coalface for these people with a leg ulcer.
Yeah. And the community nurses are in and out in 2 minutes. They say they don't have time to wash the legs. You know, the constant gripes I hear from patients every week are they rarely see the same nurse twice, and that nurse A will come in on a Monday and say you need dressing number 1, and then nurse B will come in on a Thursday and say what have you got dressing number 1 on for? You need dressing number 2. And before COVID, when I was doing a lot of research into peripheral arterial disease, I used to do a lot of home visits, and I very often used to go into patients' home, and I would see a pile of boxes, usually in the corner of their dining room or living room, with hundreds or thousands of pounds worth of dressings that have been dispensed. And of course, once they've been dispensed, they're never going to be used again. But we all know that there's virtually no evidence to support any one dressing over another. We're getting slightly off the subject of foam sclerotherapy here, I know, but I can rant about leg ulcers for a long time. But you know, it's just shocking, and it makes me very sad. And it's not improved. It's not improved in my time, I don't think.
Right. Well,
Despite the nice guidelines. I know you spoke to Hugh, and Hugh did some work to look at the impact of NICE guidelines when he was with us as a research fellow, and I think there was perhaps a little bit of an increase in referrals. But we've worked really hard in our location to make referral easy. We've got a one-page referral pro forma that we don't insist on. In fact, we don't want referrals from GPs. We want referrals from the nurses who are treating the patients. So we accept those. We have a dedicated email address so that they can, fill in the form electronically, hit the button, it bangs off to us, and we see them just as quickly as we possibly can. But despite that, they're not getting well served. Anyway, I say we're getting off the subject of foam sclerotherapy.
No. Well, the reason, no, I don't think we are really, because here's the thing. A lot of learned societies and luminary phlebologists tell us that we need to be referring, people need to be referred within 2 weeks if they've had a leg ulcer for more than a certain period of time. They need to go to a specialist unit. They need to then have a duplex ultrasound scan. They then have to have endothermal ablation as the first choice procedure. Now, this is not quite off the subject, because I would argue that, as we've stated, the patient-reported outcomes from foam sclerotherapy are equivalent to endothermal ablation.
Yes.
The recurrence rates in terms of patency and so forth are probably unimportant. And we know from the EVRA trial that the majority of patients who had a superficial venous intervention actually had foam sclerotherapy.
Yeah.
And the reason I talk about this in a podcast about foam sclerotherapy with you is because you're not a doctor. You've probably treated more people with foam sclerotherapy than probably any other doctor in the country, but you're not a doctor. And
No.
I think restricting the referral of people with holes in their legs, as you politely call them, to a specialist vascular unit run by vascular surgeons who have a particular interest in endothermal ablation is only going to clog up the system more and make the problem of venous leg ulcers worse. I was trying to tempt you into the suggestion that ultrasound-guided foam sclerotherapy is the only solution. We haven't got enough catheters in the world. We haven't got enough people who can do endothermal ablation. And it should not be the first choice, I would suggest. What do you think to that?
I agree. I think that what the criteria that you were talking about were basically the NICE clinical guidelines that came out quite a long time ago. I always thought they were slightly flawed, particularly the costs involved with the procedures. I thought were a bit way out, but hey ho, that's what they came up with. So I'd say, perhaps controversially, that my opinion of NICE has gone down considerably.
Yes.
In the last few years. I don't think that they're doing a great job at the moment. They seem to be, well, anyway. I would say that the majority of patients whose veins we treat for ulcers, either healed or active, are treated with foam sclerotherapy alone. Many of them tend to be elderly. I think foam sclerotherapy is very well tolerated. I've treated many patients in their 90s. I think the oldest I've treated I've done two 95-year-olds, and they just come in, lie on the couch, get on with it, go home again, and they're absolutely fine. We're not looking for long-term results in many of these patients. We're looking for a short, sharp effect which will heal their leg ulcer and keep it healed. So I think foam sclerotherapy is a fantastic treatment if patient has superficial venous incompetence. As I said earlier, I think that the compression is a bit like first aid. You cut your finger, you put a sticking plaster on it. But as I often say when I speak to GPs or nurses in primary care, a leg ulcer is a symptom of something. It's occurred for a reason, and unless you investigate what that reason is and deal with it, then the likelihood of you having a good, durable, long-term outcome is small, I would suggest. But I have to say that that during EVRA, we participated in EVRA, and we kept the screening logs. It was a fairly small number of patients. I think a lot of that is due to the fact that it had to be an ulcer of less than 6 months duration, because I think that's nonsense. I mean, I think if Alan Davis wanted to do a nice new trial, he could perhaps do a patient of any trial of any patient with an ulcer of any duration and superficial venous incompetence, and let's see what that shows. I suspect it would show a similar thing, that there's unbelievable healing rates. As you know, we published a case series back a long time ago now, 2010, I think, in the European Journal, 132 ulcerated legs treated with foam, and we had healing rates of over 80% within 2 months of treatment, recurrence rates less than 4% at 2 years, and that was all comers. So, so I think it's fun. I'm a fan. I've always been a fan since day one. Nothing's changed that. I quite often, when I'm treating patients, I have a little bit of, we have a bit of a banter going on and what have you, and they quite often will say to me, "Blimey, you get excited about it, don't you?" And I say, I show them, I say, "There's the vein on the screen, watch what happens, woo, goes white," and everybody gets excited. And I say, I do get excited about it because although I've been doing it for 20 years and I've treated tens of thousands of patients, it's still too good to be true to me. Best things in life are simple. I'm very simple. So, and I love it. I think it's so effective. It's such a brilliant technique. I don't understand why more people don't do it, apart from the fact that they can't, because they're not adept at ultrasound. They're not good at cannulation. It amazes me the number of people who do endothermal ablation and then do stent phlebectomies for the tributaries.
Yeah.
Bizarre. Anyway.
Yeah. Gareth.
Yes.
I think that I think it's great that you're going to be coming to the British Association of Sclerotherapists meeting next year in May. For those who are watching, Gareth has very bravely accepted an invitation from the BAS to perform a live demonstration of the English method. And I think it's a rare opportunity to see how it should be done properly, with the cannulas being placed along the length of the trunk into the tributaries, the leg elevated, small aliquots of the appropriate doses of foam sclerosant, and of course the bandaging technique and so forth, and the aftercare. We've got a workshop at the beginning which you're going to be participating in, and it's a good opportunity for people who are not familiar with the English method to get to see it firsthand. And I'm looking forward to that immensely. It's been a great pleasure, Gareth, to catch up with you again.
Well, thank you for asking me, Haroun. It's nice to see you again, catch up after all these years. I look forward to seeing you next May, I think it is, isn't it?
Yes, it's May. It's May the 12th, 13th.
We'll be able
it's in Windsor.
Maybe he wants his veins treated.
Maybe he does. Maybe he has.
Well, his granny had a leg ulcer.
Yeah. Sorry, say that again?
His granny had a leg ulcer, didn't she?
Did she?
Queen Mother famously had leg ulcers, yeah.
I didn't know that.
Yeah.
You didn't treat her?
I didn't. No. People far more important than me, Haroun. Yeah. Well, I'm still waiting for my knighthood.
All right, then. Well, all right. Well, thank you very much, Gareth. It's been a pleasure.
Absolute pleasure. Nice to talk to you.
Nice to talk to you. Bye for now.
Take care. Bye-bye.